Thank you very much. The previous two speakers are a hard act to follow, but I'll try my best. So I'm going to talk to you about two research projects that were funded by the HRB. The first was a project grant, and the second was through the Interdisciplinary Capacity Enhancement Awards, the ICE Awards. So I'm going to start off with the first, which is around aspirin and cancer. So we've been doing some work for a number of years looking at the effects of aspirin, particularly on breast cancer. Aspirin has been around a long time. It's over 100 years old at this stage. It's one of the most used drugs in the world. It's on the WHO list of essential medicines. Evidence is emerging from not just observational but randomized controlled trials that aspirin can reduce cancer risk, metastatic disease, and death. So more evidence in terms of how it works and the mechanisms is required, but that's part of the work that we're doing. So just to say quickly, aspirin can save lives. For every 1,000 people aged 60 that taking aspirin every day for 10 years, 17 lives will be saved, with 2 to 3 deaths caused by the aspirin because of the side effects of the drug. We aren't sure about which people will benefit from taking aspirin in terms of cancer, so more understanding of that is required. The problems with aspirin are that the first 3 years, there's a high risk of bleeding, complications. However, after 5 to 10 years, the risk of cancer is significantly reduced by up to a half in some cases, particularly colorectal cancer. So just to show you some slides briefly around the evidence that's already out there about aspirin, a cohort, or a large consortium in Oxford University pooled all the data from all of the randomized controlled trials looking at aspirin and placebo in cardiovascular trials. They looked at cancer as an outcome. They looked at the risk of cancer, they looked at metastatic cancer, and also death from cancer. So they found basically that after 5 years of aspirin use, your risk of cancer is reduced by about a third. By taking aspirin for several years before your diagnosis, you have about a third risk reduced metastatic cancer, distant metastases. And this is meta-analysis from 5 randomized controlled trials that had about 1,000 cancer cases. In particular, the cancers that are significantly reduced in terms of distant metastases are colorectal, which is well known now in terms of the aspirin effect is significant, but breast is the one that we're interested in, and we find that there's a 50% reduction in nodal distant metastases for breast cancer, although not statistically significant. The numbers were very small here. So just to give you some facts about breast cancer, in Ireland, 1 in 10 women have a chance of developing breast cancer over their lifetime. Women are surviving breast cancer for a lot longer, so we need to understand more about the medicines that they take, the side effects, and whether they work in specific women but not in others to personalise the medicine. We know that breast cancer is on the increase. We have an ageing population in Ireland, so this is predicted to increase. These are worldwide figures, not for Ireland. So just to talk about the first study we published in August 2014, it got quite a bit of attention in the media. It was looking at the use of aspirin pre-diagnosis of your breast cancer on lymph node status, so whether the cancer has spread to the lymph nodes. So your status at diagnosis, was it impacted by whether you're on aspirin before your diagnosis, and also we looked at mortality in those women. This was a nationwide population-based study using the National Cancer Registry as our base, and we then were able to link that information to pharmacy claims data from the primary care reimbursement services. So just to give you a summary, the women basically who were on aspirin before their diagnosis had about 11% reduced risk of lymph node positive disease at diagnosis. And the increased, that risk reduction was improved with more frequent use of aspirin more regularly and for longer duration. We also found that the women who took the aspirin before diagnosis and had node-negative disease, that was no spread of their cancer, had a significant 45% reduced risk of death subsequently when we followed them up. So that was a very important finding. This was not found in the node-positive women. So just to say about this population-based study has now led to research that we're doing with the Irish Cancer Society through the first collaborative cancer research centre, Breast Predict, to identify which women are more likely to benefit from taking aspirin in the long term, sort of in terms of reducing their risk of nodal status, node positive disease, and reduced mortality. So we're looking at this in terms of biomarkers of response to aspirin. We're also looking at response to statin therapy. So this is work that's ongoing, and this involves a wide network of collaborators from many different disciplines, including biologists, cancer, medical oncologists, a very diverse disciplines across Ireland, across the islands of Ireland. So hopefully we'll have some results in the next year or two. And then, so the second study is really about how well women take their hormone therapy. So hormone therapy is prescribed for women who have estrogen receptor positive disease at diagnosis. So about 50% reduced recurrence with the use of this drug. However, we found in our own research in Ireland that about 22% of women stopped taking their drug by 1 year, and about 35 at 3.5 years post initiation of hormonal therapy, which puts them at increased risk of recurrence and mortality. So what we've done here is we looked at a nested case control study where we looked at cases that had recurrence of their cancer and matched them to women who hadn't had a recurrence of the cancer. And we looked at their persistence to their hormonal therapy. We found that women who are non-persistent stopped taking their therapy for more than 6 months were more likely, 3 times more likely to be at risk of recurrence compared to the women who were persistent to therapy. So this is not surprising given that we know what we know about hormone therapy and reduced recurrence risk. So again, this was some research that got some interest in the media. This led on to some research that we're currently doing or have been published now, is identifying what are the influences, the modifiable influences that characterize why women stop taking their medication therapy. So this is trying to understand the behavior and trying to move towards behavior change, which I think is a key to getting evidence into practice, healthcare practice and policy, and also to improve health outcomes for patients. So if we can change behaviour, I think we've got a speaker later today talking about behaviour change. This is the key to bringing the evidence into practice. And we have identified barriers and enablers to why women don't take their hormone therapy. So we interviewed 31 women who either were non-persistent, non-adherent to their therapy, and found a number of domains that were significant in those behaviours, non-persistent behaviours. So just to give you, this is where we're going from population to patient level data, where women felt that they weren't getting, they didn't like taking the drug. It gave them side effects. It actually made them feel worse than having the cancer. I want to be finished with the treatment. I had an operation. I had this chemo. I've had this radiotherapy. I don't think I want this anymore. So it was trying to understand why women are not happy in taking these drugs, and to try and see if we can change that behaviour. So this is work that we're hoping to, we've identified some of the important barriers and enablers to improve therapy taking and survival. We need to use this to inform further research in developing and evaluating theory-based interventions in improving this medication taking behaviour. So I'd just like to thank a number of people, particularly the postdoctoral researchers who worked on the 2 projects, Dr. Ian Barron and Dr. Katrina Kahar, and all the women who participated in the research that we did. Thank you very much.